we discussed the role of transplant, and various speakers have discussed in their talk already, right? So I was discussing Dr. Prasad whether we really need to do this talk. Okay, so what I will discuss is, so before I start, how many of students they have have a proper transplant unit in their center, or they have seen transplants happening, right? Okay, so my job is much easier. So we have seen it and you know it. So the job is over. So what I will discuss is the role of auto transplant in various lymphomas, and I will focus mostly on the ones which are commonly done. Okay, and then a bit of autologous stem cell transplant procedures and bit of stem cell mobilization and conditioning, and then role of allogenic stem cell transplant, which is mostly in Hodgkin's and TNHL. I will not discuss about situations where we usually don't do allogenic stem cell transplant. You may get published data, but there is hardly any center which does an allogenic stem cell transplant for relapsed refractory DLBCL, right? So we'll discuss which is practical. Okay, so brief history, as I said. So the proper terminology is high dose therapy and then autologous stem cell transplant. Okay, so it is a high dose therapy that helps the patient in curing them. So 1978, NCI, the first data of transplant. 1980s, you got the first RCT in Hodgkin, and after 10 years, second RCT. There was two RCT in Hodgkin, and then subsequently the RCTs happened in DLBL. So let's first see DLBCL. Okay, so DLBCL, you have three situations: CR1, CR2, and beyond, and CAR-T. Much has been already discussed. Okay, so intuitively, so patients who are high risk or aggressive DLBCLs, you may thought that why not transplant them in upfront? So if you think that the relapse risk is high, why not transplant them? So this is the SWOG data with R-CHOP backbone. Those who are PR or CR randomized transplant versus no transplant, you see there is no difference, right? So very important study that transplant doesn't help in CR1. Is there any subset where you will do a transplant in CR1 DLBCL, right? So that is something which comes up, and probably double hit lymphoma where it's a high risk lymphoma, but however the percentage of double hit lymphoma that we're going to really see in the clinical practice is 2 to 3% of the entire DLBCL, right? Very small number. Obviously the data will be very small. The largest data is from this Landsberg et al. Paper is from US. 19 US centers gave their data retrospectively, various regimens, and that is the best data available for auto transplant in double hit lymphoma. And this is the result, So if you see the patients who received R-CHOP and they received auto transplant, their outcome is better than just receiving R-CHOP and no transplant. But see the number, 8 patients, right? This is the number based on which we recommend transplant, right? So we have to be careful whether to do a transplant in autologous transplant in a double hit. So my approach is to give something more intensive, say give REPOC and finish the treatment. The outcomes are almost similar rather than giving R-CHOP and transplant. Okay, so two studies which are randomized in DLBCL relapsed refractory. So this is CR2 now. So we discuss CR1. CR2, there are two studies, PAMA and CORAL study. Very simple design. You can see relapsed DLBCL, 2 DAP, response, do transplant versus continue 2 more. So 4 DAP. Okay. CORAL study, they didn't answer which is, they're asking which is a better conditioning or salvage regimen, whether it is ICE or DAP. Transplant was common for both. So by that time, they knew that transplant is getting the, transplant is the standard of care. So they're just looking at which is the better salvage regimen. So PAMA was the first study. Interestingly, Parma is a place in Italy. So all day you heard that all the names in lymphoma is name of a place. And this is also a place in Italy. And a small general knowledge for residents, Deauville score is the name of person or place. Excellent. That's all again in France, and the proper terminology is how to pronounce it, Deauville. Okay, DOVIL. It's a French word. Okay, so Parma study. So this is the result. Response rate 84%, significantly improved EFS as well as overall survival. Now you can see the overall survival. This was in 1990s, and this is the second study, CORAL study, right? As I was alluding, so transplant was common. We were just looking at whether RDHAP is better or RICE is better. So it's a randomized study. And you see something here that patients 197, 191 each arm, see how many patients underwent transplant, right? 50%. Okay. So that's what the real world scenario is, that if you take 100 patients of the last DLBCL today and give them salvage, only 50 will undergo transplant, right? 50%. Because rest of the 50% will either progress or they will not get the desired response that the transplant patient will be comfortable doing transplant. So 50%. Okay. So there's something more here, mobilization adjusted response. I'll come to that. Just keep this word in mind. So I'll come subsequently. So this is the breakup of this data. So interestingly, coral study was in the rituximab era. Important. So rituximab was an important development in DLBM. So what happens? The patients who receive rituximab and they relapse. So previous study, that is Parma, was pre-rituximab, right? So overall, there was no difference in overall survival, whether you use RDHHP or RX. Both are similar. So if you see the patients who received rituximab before, okay, so some patients received rituximab and some didn't, because rituximab was approved in between when the study was ongoing. So when they looked at patients who received rituximab before and they relapsed within 1 year, their EFS was only 20%. So remember, important number, patients receiving RCHOP relapsing within a year, maybe the outcome is around 20%. But if you see patients who have relapsed after a year, even though they have received pyridoxine, around 50%, right? So these are the numbers which you should know, and important to counsel those patients when they relapse. Okay, so prior rituximab definitely is bad. So now important thing is that all relapse refractory DLBLs we can't club together. Okay, so this is the 4 categories that I have enlisted. When you give R-job, a group of patients will have progression, primary progression, right? They're progressing when you do a PET scan. Second group is they will have a response, partial response, but they will have significant disease at the end of 6 cycles. Okay. And third category is they are in CR, but they are relapsed within a year. And the fourth category is they are relapsed after a year. So these are the 4 important categories. And outcome of each category again will depend whether they are eligible for transplant. So if a patient is say 65-year primary progressive PS3, that is not the same as a patient who is 40-year primary progressive but fit, right? So both will be different and the outcomes will be different. So is there any study which has looked into this group? So if you see, there is the largest database of refractory DLBCL called Scholar 1, okay, which is always the comparator for all CAR-T trials. But if you see in that trial, patients who are mostly primary progressive or those who are refractory to R-CHOP. Okay. So is there any data which has really looked into those patients where there is an intent to do a transplant, right? So this is the data from MSK. This is the only data I could find. And what is happening here is that patients, if you can see this, patients who are primary refractory, that is primary progression, this is the outcome, 20%. So that's a bad group. But the patients who are responding, they are a partial response. If you give them a second line salvage and do transplant, it is around 40%. So this is the upper end group. So then when they added PET into it, they found that the patients who attended PET CR after giving a salvage, even if they are refractory, so refractory definition is here, they didn't achieve a CR with R-CHOP, okay, but they achieved a CR, Deauville 1 to 3, even 4. The outcome is 30 to 50%, right? So now we need some prospective data. So this was retrospective from MSKCC. This is the ORCHARD study comparing 2 kinds of anti-CD20 monoclonal antibody. So that is not important what I have, for which I have made this slide. So important is this. So you see, what is the prognostic value of pre-transplant PET? All patients in this study underwent a pre-transplant PET. So this is a prospective, well-conducted study. So this will give you the answer that what happens if the patient is pre-transplant PET positive, right? The outcome is 30 versus 70, right? If the patients are PET negative pre-transplant, the outcome is 70%. Okay. So what happens to PET PR, right? So we discussed, suppose a patient is relapsing within a year, we give salvage, they responded, but some query disease. So this is the data, this is the largest data from CABMTR, and this is a registry data which they collect prospectively. And when they look compared CAR-T and transplant in a PET PR after giving a salvage, more or less similar, 40 to 45%, nothing different, right? Even if they are early progressors or early relapse or late relapse, right? So that means if a patient has received a salvage, attend a PR, underwent a transplant, 40% outcome. So now you can ask that what is PET PR? So PET PR, there will be some subjectivity. You may have a patient with PET PR with one single site, you may have a PET PR with multiple sites, right? So that's a heterogeneous group. What I use the term is a good PR, right? Something good, looks good in PET scan. And you can, that's the feeling of the oncologist, and that will be the bias in all these studies. So this is the slide Dr. Suchitra has shown you in the last presentation. I have just added one arrow here. You can see everything was same. Okay. So this is 75% patients will have an early relapse in DLBCL. Only 25% will have a late relapse. But if you give a salvage and the patient is fit, if it have a good PR, as I said, or a CR, the projected cure rate is 40% with transplant. Okay. So this is the summary slide for DLBCL. Any questions if you want to ask for DLBCL, you can clear now or you can move. Relapsed DLBCL transplant. I've showed you the transplant data, I've showed you the outcomes, PET, and this is the algorithm. Yes.
Would you go for a transplant in primary CNS DLBCL?
So you're asking about primary CNS lymphoma. Yeah, so that is, I think the talk didn't happen. Okay. So primary CNS lymphoma transplant is a recommended consolidation. This is standard consolidation. Okay. So there are so primary CNS lymphoma, you have an induction treatment, you have a consolidation treatment. So consolidation can be transplant or chemotherapy. But now there is a phase 3 RCT which has settled the score that transplant is the standard of care. Yeah. Okay. So let's move to mantle cell. I think mantle cell very nicely discussed by Dr. Ranjit in the morning. So in a young fit patient, rehab, R-CHOP, transplant, maintenance, rituximab, right? This is standard. So he discussed about MD Anderson approach of just giving hypercivard and not do transplant. That is there. Okay, so this is the table where you can see that this is the MD Anderson approach. Okay, so integration of RRC came from Nordic group and also the European MCL network. Okay, these two groups are important who introduced cytarabine into R-CHOP in the R-CHOP RDR like backbone. And then the LISA group introduced maintenance rituximab after transplant. So these are the four groups actually which done everything for mantle cell lymphoma that you see in a young fit patient. So this is the data of transplant. Okay, this is the European MCL network. Pre-rituximab era, you can see R-CHOP and transplant versus interferon maintenance, clear-cut benefit in EFS. This is the data again from the European MCL network. So both the studies are from European MCL network. And you can see R-CHOP RDHAB, and you can see at a median follow-up of 6 years. See the difference. So they are asking only addition of cytarabine, important. Transplant was done in both the arms. Okay. So what happens if you add cytarabine to a R-CHOP backbone? And that improves the PFS from 4.3 to 9.3 years, 5-year improvement in progression-free survival. So it is not the sign data of adding ibrutinib to BR and improving by 25 months. Okay, that's different. Okay. So this is the improvement in PFS by 5 years, right? But you can ask me why there is no OS benefit. Still update as 2021, still no OS benefit. The overall survival remain the same. And that's how the mantle cell lymphoma paradigm is all about. So this is the data of rituximab maintenance post-transplant. All patients received RDHAB, rituximab every 2 months for 3 years versus nothing. So you can see the difference in terms of EFS and OS data was immature. There are very few events in overall survival. You can don't take this curve as important. So this is important as event-free survival, and there is any for event-free survival. Median has not reached for either. So this is pretty a standard of care. Everybody practice this. And so as I said, R-CHOP, RDHAB, transplant, and maintenance rituximab is the standard of care. So triangle study, Dr. Ranjit has discussed today. Okay, so we don't have a full paper yet. But interestingly, it didn't refute that transplant didn't help. Okay, so whether adding ibrutinib to transplant, does it improve, or adding transplant to ibrutinib? So ibrutinib anyway you have to add, but if you add transplant to ibrutinib, does it help? It didn't answer that question, right? So, and we are still wait to it. Median follow-up is 30 months. You have seen mantle cell lymphoma data. It goes for years together. Three or 30 to 35 months is not a good median follow-up to comment anything on mantle cell lymphoma. Okay, so you have to wait. So this is the summary. Young fit to undergo transplant. This is independent of histological subtype. So whether I get a blastic, I get a pleomorphic, I don't know. Like I don't have any data to diffuse a transplant to a blastic mantle cell lymphoma, right? So though they are high risk, but this is the treatment, right? No role in CR2. Important. If the patient relapses, there is no data that transplant helps in CR2. It is always CR1. Okay. And addition of BTK inhibitor is promising, but we need to wait. Any questions in mantle cell? Yes. Yeah, so that question was asked, I think, during the discussion that, so my feeling is there is nothing called early stage mantle cell lymphoma, right? It's a misnomer, right? So if you ask me how many cases I have seen in 4 years, one case I have seen which is early stage, but we didn't do the full workup. If you do the full workup, it will be advanced most of the time, right? So you're not going to encounter that situation. But having said that, if it is a young fit patient, true early stage disease, that is a low risk disease to do a transplant, right? In that case, you can just do the chemo.
Nearly 80% of the cases are already.
Yeah. So if you're finding it a limited stage, probably you have not done the complete workup. If you do the endoscopy, you do biopsies, you'll get somewhere the disease, So that's how mental.
No, it is not mentioned anywhere, even in limited stage.
Yeah. So in limited stage disease, because the data, all the data is in advance. So if you see the data of transplant, they're all in advanced disease. So I will not applicable or kind of reciprocate that to a limited. So that is the whole reason why I will not recommend the transplant.
Not even mention separate guidelines for the very stage.
Yeah.
There is no separate entity for
Yeah, there is no separate entity. There is no separate entity. Okay, so next coming to follicular lymphoma. So follicular lymphoma, again, the history is very long, right? It's a low-grade lymphoma. The patients will have initial response. They keep on relapsing. They receive 2-3 lines of therapy, and they remain well preserved. You can do a transplant later also, right? So the important concern in follicular lymphoma transplant is as they live longer, they develop this complication of second malignancy. 15 to 16% rate of second malignancy after a transplant, and that is highest in any autologous transplant data for any lymphoma. And the basic reason is that these patients keep on relapsing, and they do get transplant in second or third line, and then the basic reason why they develop this malignancy is multiple line of chemo, and then you do a transplant. So that's important. So there are 3 RCT in the pre-rituximab era. I'm not discussing all that. So, but there is a consistent benefit in progression-free survival. It has not shown a OS benefit, but definitely increased risk of second malignancy. So these are the data with upfront data. Okay. So this is the study which is very important in follicular lymphoma transplant, which is in the relapse setting. Okay. So data in upfront setting is not there. This is the data in upfront setting, no difference. Okay. There is a RCT already done. So there is no difference of survival if you do a transplant in upfront setting. So what happens in relapse? CUP trial. The name is CUP. CUP. C for conventional chemo, U for unpurged, C for what is purging, by the way. The concept of purging is that when you collect a stem cell with an active marrow disease, there is a fear of contamination of stem cell with the disease, right? So that is the thought that why these patients are relapsing. So that's why there are ways how to remove those malignant cells by doing some in vivo or in vitro maneuvers. So what typically they do give rituximab. 4 doses of rituximab before you collect the stem cell weekly, right? This is the way people used to practice this purging, but probably this data has already settled the score that it doesn't help, right? This is the 3-arm study, and one 3-arm, one is unpurged, second is purged, and third is conventional chemotherapy. You can see the results. The combined purge versus unpurged, there is no difference in outcome, but transplant did benefit than just giving chemotherapy. So in relapsed follicular lymphoma, CUP study showed that transplant improves EFS as well as overall survival, and this is also in the pre-rituximab era. So do we have any data in the rituximab era with a standard backbone? So what is happening is if you see previous data of follicular lymphoma, the standard conditioning is TBI based. Most of the data are TBI based. That's why the second malignancy is. There is only one data with beam regimen, which is standard, and with rituximab, And if you can see 70 patients, and the patients who are in second remission, and you do a transplant, there is a plateauing and there is a benefit beyond that. Like if the patient is CR3, CR4, I don't think that's the right time to do a transplant. You're going to increase the risk of second malignancies. The benefit is very less. Probably it is in the CR2. Okay, to summarize, the role of transplant in upfront setting is limited, but optimal scenario is this CR2 in agricultural disease. Important, if your patient is relapsing within 2 years, please rule out transformation. That is the most common cause when they relapse within 2 years of time, right? Before you jump and think that it is follicular lymphoma. Okay, so standard conditioning is beam, and any doubt, any follicular lymphoma. Great. So T-cell lymphoma. So as already discussed, there is no RCT which has compared transplant versus no transplant in T-cell lymphoma, unfortunately, right? But there is a RCT of auto versus allo in T-cell lymphoma. Interesting, right? There is no RCT only where the transplant helps, but you have the RCT of auto versus allo by the Germans, right? I'll show why that happens. I'll show you. So only 2 diseases which are T-cell lymphoma, they are very good prognosis, alpha positive LCL and truly localized nasal type of NK cell. Rest all are high risk, right? So rest all you can think that transplant may help. Most data are registries or retrospective. Now, what happens in a registry data is that if you see the transplant rate in T-cell lymphoma, it will be 70%, 50 to 70%, right? But that is not the real world scenario, right? Because in the registry, the data that is registered is only for those patients and maximum patients who underwent a transplant, right? Most of the patients will default, they will not. So, you need a prospective data to understand how many patients really go for transplant in PPTCL, okay? So, this is the table showing everything, okay? So this is the NLG data. This is the largest data, 160 patients. Okay. And you can see the breakup here. And you see the rate of transplant 70, 60, 74. The only data that is from the registry data, prospective US registry, only 30% rate of transplant. And that is actually the truth if you see the real world. Okay. So 4-year EFS, 34 to 35 to 40%. The data from German, Italian, MSKCC. So standard outcome data that you will see, or similar outcome data you will see from the various results. And this is the most latest from the Netherlands Cancer Registry. Netherlands, they have a very good cancer registry, and they have data of every patient, what happened to them, and they know the exact cause of death also, why the patient died, right? You can see many publications from Netherlands coming from many various cancers, right? So this is from 1989 to 2018 and 1400 patients, right? 1400, big data set. And if they answer two important questions, whether etoposide adds to anything or whether doing transplant helps in T-cell lymphoma. So one thing they found that only ALK positive LCL etoposide helps. The rest all it didn't help, right? The opposite is like transplant helped in everything except ALK positive. No, interesting. So same ALK positive LCL is common in both. So this is the breakup here. You can see ALK positive, AITL, and PTCL, NOS. So important why this data I have shown you is that though this is a registry data, but this is a very well kept registry data of knowing cause of death in every patient. So this will actually tell you that what is whether there is any merit or what is the margin of benefit, right? If you are getting some margin of benefit in this kind of data with 1400 patients, there is some merit of recommending transplant in this group of patients. So to summarize, why no RCT? Yes, I told you I'll tell you the reason why no RCT. So for RCT, important is there has to be clinical equipoise. That means all clinicians who are involved in the RCT, they should believe that both the treatments have a equal or clinical equipoise. You know why there is no RCT yet in T-cell lymphoma? Because some believe that transplant helps in everybody or every patient, and some believe that it doesn't help. Right? That's how the thinking was that. And that's why there is no RCT yet. So, and second thing is that in the registry data, you can do many multivariate analysis, but it can't account for a physician bias to recommend a transplant, right? If I think that this patient should go for transplant, that cannot be accounted by multivariate analysis, right? This is physician bias, right? So you need that kind of study to answer that whether it helps in a T-cell lymphoma. So this is the standard line you'll get for all T-cell lymphoma. I have just made it italics. So considering the poor result of conventional chemotherapy of patient with PTCL, high chemotherapy followed by ICT has been widely employed as a considered strategy for patients in CR who have relapsed refractory despite the absence of any prospective data. So this is the standard line you'll get in all publications. So probably the consensus. So IMA has shown this, that there is a study called transcript trial, which is enrolling, and it is there in the clinical trial.gov, and very interesting design. I love this design that the randomization started from here, right? From the day one. What happens is that if you have randomized patients who are eligible and they are in CR, that is a false or a biased idea, right? This is important that from the day one you randomize and then prove that it helps or not. Okay. So in this study, many patients will fall out. They will not be eligible for transplant. Still, it will answer that whether it helps in a randomized way. To summarize, AITL, PTCL, NOS, ALK negative in young fit patient, no benefit in ALK positive. I agree. ATL and CT cell, interestingly, these are the two T cell lymphoma. Probably allo is better than doing an auto transplant. The data of auto transplant is very limited. Probably it doesn't help. Standard consideration is B. Hodgkin's lymphoma. So I discussed two important studies, GLNI and ST01. So these are the two randomized studies. And first randomized study of Hodgkin has 20 patients each. This is a randomized study, 20% in each arm. This is the study. Okay, you can see Dexa and beam transplant. And this is the German study, and this is the BLNI study. Okay, so these are the two RCTs in Hodgkin. So things changed when PET came in Hodgkin. In PET came, right? PET data came, things changed very rapidly in Hodgkin's lymphoma space. So this is the first data from MSKCC group, from Craig Moscowitz data. You can see that those who are PET negative, the outcome is 60 to 70% versus 30%. And this is after even if they receive 2 lines of salvage. You can see this data as a prospective data. If the patients are refractory to ICE, they get GDP. But if they're PET negative, they're negative. And you do a transplant, their outcome is 70%. right? Which is unlike in a DLB. We'll not get this kind of data in DLB. Okay? So then everybody tried to attempt, let's improve the PET CR rate because everything depends on pre-transplant PET. So many attempts are made. We have BB based regimens, we have CPI based regimen. You see the PET CR rate has dramatically improved over the years. Now we have got 80 to 90% PET CR rates in relapse refractory Hodgkin. So this is a data. So now what happened is that when you use novel agents, right, immunotherapy early on in relapse setting, you have this notion that probably this patient accepted a novel agent or immunotherapy, they should get an allo transplant. So is there any data that you do a transplant after immunotherapy, auto transplant in Hodgkin? So this is a data from US multiple center. And you can see that patients have received multiple salvage and PDL1 no inhibitor is one part of salvage. And if they have been PET CR, okay, so you can see PET CR, their 18-month PFS was 80%. And importantly, pre-transplant PET positivity with immunotherapy doesn't matter, probably according to this data. But what my thinking is that if you give immunotherapy pre-transplant, you may get some FDG positivity, which may be some immune reaction, may not be disease. You couldn't do the biopsy, you think PET positive, but actually they are in CR. Probably that may be the reason why you see this of recruiting stem cells from the marrow to the peripheral blood. So what are drugs used? GCSF and Perixafor. Two drugs are used to mobilize those stem cells. How do they act? Very interesting mechanism. GCSF, there is no GCSF receptor in the stem cells, right? There is no receptor like that. So what that does, they activate the neutrophils, there is proteases, and they break those bindings from stem cell and stromal cells. Okay, that's how the stem cells come into the circulation. We have Perixafor, which is an inhibitor of CXCR4. So same mechanism, but it acts on a specific receptor. So minimum stem cell dose that you need is 2 million per kilo. Optimal is 5. Okay. So I told you I will tell about mobilization adjusted response rate. This is important. So what is mobilization adjusted response rate is that you when you give a salvage chemotherapy, you are going to damage some amount of stem cells, right? So some patients may not collect, even if they get a good response and you do collection, there is no adequate or minimum amount of CD34 that you need. So that is also important when you choose salvage regimen, right? So the definition is so this is the definition is patients who have CR and PR and they are able to collect adequate stem cells. So what is that response rate? So that is around 50 to 55%. And whether you choose GDP, DHAP, ICE, they all are similar. So 50 to 60% patients will have mobilization as a response rate of 50%. So there are certain reasons why they have poor mobilization. You can see age is, these are the factors prior radiotherapy, and important is obesity, diabetes, and they have all little do with SDF, stromal derived factor. Remember that is important to bind stem cell. If the patient is diabetic, they are obese, they have more SDF activity, and that leads to poor mobilization. Okay, so these are the way how do you mobilize stem cells. 4 different approach: GCSF, chemo mobilization. Now, chemo again has 2 parts. One is whether it is disease specific, then there is non-disease specific, and fourth one is GCSF, Perixafor. So what do you do here? You give GCSF and then you collect. Very interesting, not very complicated. 4 days of GCSF, then you collect on the 5th day. Now, in GG specific, you use the cancer chemotherapy that you are using to collect stem cells. So, when you give a chemotherapy, salvage chemotherapy, there will be a certain amount of neutropenia, right? When there will be a rise in count, that will again lead to more stem cell in the marrow, and that leads to more efflux of stem cell to the peripheral blood. And when you add GCS to that, so there will be more stem cell collection. That is the basic hypothesis. So, that's why it calls the chemoemulation. Third one is non-disease specific. Like suppose you have already completed your planned chemotherapy, now you want to collect. So you can give some amount of some kind of chemo like cyclophosphamide that you typically use, and then you collect. And the fourth one is you give GCSF and give Perixafor on the day 4. So these are the protocols that you use in TMH. So when you use GDP, okay, so we give GCSF on day 10 and then start monitoring the CD34 at around day 12. And as soon as we get a CD34 value above 20, we think that we are going to collect enough. So then we start for collection. Same is for DHAP. And when there is a non-disease specific, like I said, this is our endocrine mobilization chart that we use. Okay. So coming to a little bit about conditioning regimens, beam, lace, LEAM, BEAK, CVB, augmented CVB. So beam and lace is the most commonly used conditioning regimen we use in our center also. There are some data of LEAM from AIMS, from Atul Sharma sir's retrospective data. When they just replaced BCNU with Lomustine, and CVB is something which came from Stanford. Lace came from Hammersmith. So, and Beam came from UK. So these are the various centers have contributed this regimen. And the doses used in this regimen probably are arbitrary. There is no data that why this dose was used. There is no pharmacokinetic studies done to understand this is the right dose for conditioning. Okay. Okay, this is the retrospective analysis that we did from our center. So this is the so just focus on the doses of chemotherapy here. If you see in LACE, you have lomustine, you have etoposide 1 gram per meter square, very high dose etoposide, very high dose cytarabine. But if you see beam, etoposide and cytarabine, the dose is very less, 200 melphalan. So if you see LACE, they have high dose cytarabine, high dose etoposide. So you have moderate to standard dose in beam. Okay. So why, whether to choose anything different in scenarios? Suppose you want a patient where you want some CNS penetration to happen. You can use LACE because it has more RC, more etoposide, right? Say in primary CNS lymphoma. So in our center, we are doing a study. So we are using LACE because more RC, more etoposide may help in CNS protection. But if the patient has a CNS disease, beam will definitely be inferior because you don't have any drug which penetrates CNS better. Lomustine again has very good CNS penetration. Okay. So this is the comparison that we did. It's a retrospective data comparison from 2000 to 2011, almost 10 years. You can see 75 and 64 patients. What we found was that overall there was no difference in outcome in terms of EFS and overall survival. Both were similar. The only thing different was different toxicities. So when you used beam, the rate of diarrhea, mucositis was high. Many patients required TPN. If I have given the exact number, this is the number. So 32 versus 69. Okay. So parental nutrition is 70% patients if you use beam, right? So if you're planning a chemo and you're using beam, be ready that the patient will require 2 to 3 4 times that the patient look at total parental nutrition. Okay. Less is in that way little gentler and no difference in kind of engraftment kinetics. Overall, from our data, less seem to be better than beam, but you need a prospective data to understand that. Now, lastly, allotransplant. As I said that I will not discuss all kinds of allotransplant and all lymphomas. No, practically speaking, in these only two situations where you really do not allotransplant in real world, nobody is going to do allotransplant for relapsed refractory mantle or DLP. We have never done that. I don't think any center does that because the TRM is pretty high to recommend those kind of treatment. 25 to 30% TRM in relapsed DLP allotransplant. Nobody is going to recommend that. You have better option than that. Only two situations where you really do allotransplant is a relapsed refractory Hodgkin, aggressive T cell lymphoma in a very young patients. No, you can really do that allotransplant. So first, let's see Hodgkin. So this is the data. This is a prospective. So I love prospective data because you get the entire picture. There is no bias there in prospective data, right? In retrospective data, you see patients, how the data was collected, you have already that bias in retrospective data. But if you see prospective data, it is always good to understand what is really happening in that space. So this is a prospective phase 2 data. All patients wanted allotransplant. The PFS was 48% and 24% at 4 years. Post-transplant relapse is 60%. Okay, so allotransplant is not hanky-dory always, in relapse Hodgkin. 60% patients are again going to relapse post-transplant, right? And this is again with RIC regimen with low TRM. So this is the meta-analysis of all relapsed Hodgkin who underwent allotransplant to get a better idea that if you combine all the data of allotransplant, what is the expected survival that you're going to quote to the patient, right? So over the year, if you see increasing use of RIC regimen because of better graft versus leukemia effect, but relapse post-transplant is still more than 40%. So around 40% relapse free at 3 years, right? So this is the data that you can quote. 40 to 50% of patients will do well with relapse with allotransplant with 15 to 20% risk of treatment-related death. Okay. So I'm not going to haplo data, and that will be too much for all of you. But I will just briefly touch what is the paradigm like. So lately, there are multiple data showing that haplo is something beyond 40%, right? So 40% with mass sibling, 40% PFS. If you do haplo, you get 60%, right? So these are the multiple retrospective data. But again, one data I will quote is from CIBMTR, which is a registry data prospectively collected. I believe that kind of data when they compare haplo versus mass sibling, 40 versus 33. Again, there is nothing different. But when you look your retrospective data, be cautious when you interpret those data showing 50 to 60% outcome, right? So again, in a haplotransplant, you have two important things. One is PTCY and one is the mismatch of donor versus recipient or graft versus leukemia, which is helping. Or there is some hypothesis that you just do PTCI with mass sibling, you get the same result, right? We still don't know whether it is the PTCY or whether it is the mismatch GVL that is helping and driving those outcomes, right? But we need better data to understand that. Is checkpoint inhibitor alone is an alternative? This is the Pembro phase 2 single arm study, again a phase 2 prospective. And they had three cohorts, cohort 1, 2, and 3. And if you can see, cohort 1 was patients who progressed after auto and they subsequently received BV. Their PFS was 40%. And then just see cohort 3, patients who have relapsed after transplant, auto transplant, and they didn't receive subsequent BV. They have given 2 years of pembrolizumab, patients who are in CR. So this is the data in CR. I'm not talking about patients who are not in CR, right? You give pembrolizumab for 2 years, the patients who are in CR, 60% of them are doing well at the end of 5 years. This is the 5-year update. So if I have to choose for your question that you are asking, that we have to choose between a haplo MSD or just giving Pembro and wait for that to relapse, I would choose this rather than thinking about a treatment, going for 50 to 20% risk of TRM, 40 to 50% risk of relapse. And again, we don't have an Indian data in that situation, whether the outcome really holds true in our setting. Okay. So this is the trail study I was alluding to. There is a RCT of auto versus allo. Remember, we didn't have any RCT of transplant versus no transplant yet, but we still have we have an RCT where the Germans believe in transplant in T cell lymphoma and more so in allo transplants. That's why they did this auto versus allo transplant study. This study didn't accrue the number of patients that they intended to. They had to stop the study. In between, so after 40 to 40 month 3-year PFS was 43 versus 38. And interestingly, why the outcome was similar, it was not like they were similar in terms of everything. If you see, there was a decrease in the relapse when they do allo transplant, but there was equal TRM. So that somehow negated each other and the outcome is again same, right? But the critics argue, those who are believers for transplant based all are MAC, right? Nobody does give a MAC or myeloablative conditioning in today's era in T cell lymphoma. Definitely not. But had it been, it was a RIC regimen, the TRM would have been lesser. The relapse risk reduction is anyway there, so you would have definitely surpassed auto transplant. So this is in CR1. So will I recommend a patient CR1 allo transplant? Maybe not. But if somebody argues that they will do a RIC, that is reduced intensity, will reduce the rearm, will get the GVL, maybe in a situation which is very young, and one situation that I can recommend is AITL or ATLL, where probably an allo transplant is better than an auto transplant. From this data, what I can say that it has some merit. Okay. So these are the literatures in other data, the retrospective, few prospective. But as I said that there are very few regimens and most are RIC. And mostly if you see in all the studies, there is a plateauing in T cell lymphoma at 24 to 36 months. So there is a potential curability in that situation, and RIC has increasingly been used. And as I said, AITL is one situation where probably there is best GVL and also the ATLL. So with that, I thank ISMPO team and organizers and Dr. Prasant and Dr. Pankaj for Dr. Padma sir in inviting me. Thank you very much.